สวัสดีครับชื่ออะไรครับ
ชื่อเบลนันทิตาค่ะ
คุณนันทิตาจะมาโชว์อะไรให้พวกเราดู
วันนี้นะคะเบลจะมาร้องเพลงเป็นเพลงที่เบลเนี่ยรีมิกซ์เองค่ะ
โชว์เลยครับ
ก็รู้ว่าฉันไม่มีความหมายและพอจะรู้ว่าคงจะเป็นไปไม่ได้ยิ่งนานเท่าไรยิ่งหมดหวังเมื่อเธอรักไม่เคยจะหันมองที่ฉันไม่ว่าจะทำเช่นไรเธอคงจะไม่รักกันและก็รู้ไม่นานว่าฝันจะมีก็คงจบไปต่อให้ฉันจะรักเธอมากเท่าไรแต่ก็รู้ว่าเธอคงจะไม่สนใจแต่ยังฝันไกลหรือยังคงหวังเอาไว้ข้างในที่ใจว่าสักวันเธอจะมีฉันแต่ก็รู้เป็นไปไม่ได้เมื่อเธอคิดดูว่าฉันไม่ใช่แต่ก็ไม่เป็นไรก็อยากจะขอให้เธอเรื่อยไปในใจไปอีกแสนนานไม่รู้ว่านานเท่าไรว่าที่ฉันจะลบเธอออกจากใจว่าที่ความทรงจำดีๆมันจะเลือนหายเพื่อเธอได้รักใครอีกครั้ง
คุณหลอกผมมาตั้งแต่แรกพบมันเป็นไปไม่ได้
สวยเนาะแต่ว่าความสามารถต้องบอกว่าดีมากทำเราตกใจทีเดียวเมื่อกี้นี้พอขึ้นอีกเพลงหนึ่งมา
เล่นงี้เลย
เฮ้ยทุกคนแบบเฮ้ยอย่างนี้เลยนะนี่ก็เฮ้ยเหมือนกันว่าไงคะ
คือผมยังเชื่อมั่นในเครื่องในของผม
ว่า
คือเซ็นเซอร์ผมจับได้ว่าเขาไม่ใช่อย่างที่ผมเห็นแล้วเมื่อกี้ผมไม่ค่อยมั่นใจพอเขาเริ่มร้องเครื่องกูเสียแล้วอะพอท่อนผู้ชายมาโอ้เครื่องกูยังดีอยู่ก็ถือว่าเป็นความสามารถพิเศษที่โอเคทีเดียวมาตัดสินกันดีกว่ามา
คุณนันทิตาครับที่ผมพูดว่ามันเป็นไปไม่ได้มันเป็นไปได้คุณผ่านครับ
ขอบคุณค่ะ
สำหรับเป็นคุณผ่านเหมือนกันค่ะ
ขอบคุณค่ะ
หลอกต่อไปเรื่อยๆลูกผ่าน3 คนเลยลูก
ขอบคุณค่ะ
เชิญครับ
เขารู้จักหนูมาตั้งเกือบ10 ปีเขาไม่เคยกอดหนูเลยนะ2 คนนั้นนะ
ล้อเยอะมากค่ะอีตุ๊ดกระเทยบ้างอะไรอย่างงี้เยอะแยะมากมายแต่คือเราก็ต้องเก็บมาตลอดแล้วก็คือพ่อเนี่ยไม่ยอมรับเลยหนักที่สุดก็คือพ่อตีเลยค่ะตีบอกว่าตีเพื่อแบบอยากจะให้เราอะหายจากการเป็นกระเทยอะอยากจะบอกพ่อว่าเบลรักพ่อมากแล้วเบลก็ทำได้แล้ว
And And this is going to be our homework, our group right. Sorry, this is messed up. What type of, what are some harmless and harmful cultural practices? Can you identify some harmless cultural practices from the United States? And what are some harmful cultural practices observed in the United States? Think about that. And then can you identify harmless cultural practices observed in other countries outside the U.S.? And what are some harmful cultural practices observed in other countries of the world? I'm going to ask you to do this for homework, but it's something to think about and kind of get you out of your comfort zone. Let's now look at culture and health beliefs and practices. So cultures vary in terms of what is an illness, what causes illness, and what should be done about an illness. Do you go to the doctor? Like on my example, you go to the doctor in Thailand, you always leave with something, a pill, an injection, some kind of food item. Do you go to doctors or not go to doctors? Do you go to traditional healers? Do you go to the hospital? Different cultures have ideas about how to prevent problems. Do you eat certain ways? Do you, I know in many Southeast Asian cultures, after a woman gives birth, like I know in Laos and Hmong cultures, you eat only chicken broth and rice, I think, for the first 30 days. And you can't put the child down for 30 days. The baby should never be put on the ground for the first 30 days. What types of remedies health providers should offer will vary by culture as well. And let's look at some health service providers. So here we have 3 different columns: the indigenous health providers, Western biomedical model, and other medical systems. So indigenous, we have midwives in Laos, with many of the hill tribe groups. They have shamans who are wonderful, and people always call on the shaman. Witches, sorcerers, priests, herbalists, bone setters. Some Western biomedical providers, pharmacists, nurse midwives, nurse practitioners, physicians, dentists, and other medical systems, like the Chinese medical system, who have herbalists, acupuncturists. I always go to acupuncturists, Ayurvedic practitioners. There's so many different types of healthcare providers depending on where you are. And what about cultural explanations of disease? What causes sickness? Some have I have this broken into the body balances, emotional, supernatural, and sexual issues. So body balances. Some cultures are very focused on your temperature. Are you hot or cold? Your energy. Is your energy flowing in? Are you having a problem with energy flow? Your blood, problems with your horoscope. When I was living abroad, many people were very wed to their horoscope. They wouldn't do some things ever. They wouldn't leave the house if the horoscope said not to do it. They'd look to the horoscope before making a big decision. Some people have emotional issues that would describe explain their sickness. Fright, sorrow, envy, stress. If they're very stressed, they get sick. Then there's supernatural explanations of sickness. There's a demon who's possessed you. There's an evil eye. A loss of soul. That often happened in the Hmong culture. If someone would get sick, they would believe that their soul has lost their body and is wandering around. We have to figure out how to get that soul back into the body. So the shaman would be called to try to chant to bring that soul back into the body. And there are many sexual issues that would explain certain sicknesses. If you had sex with a forbidden person, or if you are overindulging in sex, that sometimes causes problems as well. And there are many different alternative modes of healing, so many different. These are just a tiny handful of different ones. Shamanism, which we've alluded to, where many times there are animal sacrifices to the gods to appease them so that you can get your soul back. Acupuncture, herbal medicine, there's so many different ways of healing. And this is a shaman from a Lao culture. And the shaman is he's always on top of, he or she is always on top of a type of a bench where they can shake up and down, and they've got incense, and they're always covered as if they're in a trance. And we have a short little video here that highlights a shaman delivering their ceremony. So we'll take a look at that.
Pacha shakes for the first time in America. He is anxious to reestablish contact with ancestral spirits. Chickens are used to open the altar because they have special powers to see and know. That's why the spirit of a chicken is used as a messenger and guide on journeys to the spirit kingdom.
And this is the YouTube below. As I've shared with you a couple of different times, I worked in a refugee camp, in the Chinese refugee camp, and I often witnessed ceremonies. This was a health ceremony that required an animal sacrifice. This was one of my students, and you can see there's incense burning down below. She was sacrificing chickens. Her child was ill, and so she was making a sacrifice to the gods. On the left here is I think that's a pig that was sacrificed to the gods as well. Other different type of therapies, there are many different types of therapies that are practiced around the world. And when folks come to the United States, they want to practice using the same therapies, of course. That's worked for them in the past. However, this brings many challenges within the United States. And I've been consulted many times by, for instance, school systems. In Duval County, I was called a couple of different times because they thought they had, the teachers had reported a parent to DCA because they believed that the child was being abused in the home. Yet they weren't being abused. They were just sick in some manner, and it was the healing. We've got coin rubbing, cupping, there's bruising, animal sacrifice, leeches, other. So we see up on the left, this is from coining, where you take a coin and you rub it vigorously on the skin to alleviate some pain. This is a boy from, I think, Vietnam. And you can see the coining on the baby up here on the corner. You would think if you weren't familiar with this type of healing mechanism, that they've been abused by their parent. Maybe it was a cigarette or something. So that happens often. This is a child here who's also had coining as well. You can see, it looks horrible, but this is a way of healing. There's something called cupping. These are hot cups that are suctioned on the back. They're heated, and then they are stuck on the skin. They're supposed to help with pain, but it leaves these red circles, which can be mistaken for some type of abuse. There's also leeches. Here, many people use leeches as well, and that's always, these are leeches along the spine. Anyway, there's many different types of alternative theory healing therapies that we should be aware of. And I also want to share with you the, let me see if I missed a slide. Nope. The brown bag checkup. And I love the brown bag checkup. This is always interesting. I've used this in all my programs that I've created, especially for the elderly. I always talk to practitioners about the brown bag study, brown bag checkup. When you go to see your doctor, it's always great to, or for the doctor or nurse or whomever, the practitioner, to say to the patient, I'm going to give you this brown bag. Put in the brown bag all the different medicines that you take. not just the Western medicines, but all your therapies. What are you taking? Everything that you take, your vitamins, everything you do on a daily basis, put it in the bag and bring it to me and let me take a look to see if there's any contraindications so you can see the whole patient. Because many times the provider will ask the patient, what do you take? And they'll say, I take medicine for high blood pressure. But actually they're taking all these other alternative therapies, and that could certainly have an impact on the blood pressure medication. Like my mother, she takes so many different therapies, and I said, Mom, you've got to share these with your primary healthcare provider so they know your whole picture. So anyway, the brown bag checkup is always a great way to really understand the full patient, especially someone from another culture. And this is kind of interesting. I'm looking at folk illness. Different cultures interpret the physical states that people perceive to be illness, but some of them don't have a physiological cause. For instance, something called susto. And susto I thought was interesting. It's like a fright. It's a spirit. And you need to think about that if you're working with other cultures. Susto is a fright sickness with a strong psychological overtone. Susto means it's Portuguese or Spanish word for fright, like sudden intense fear, something immediately threatening, really, really scary. For instance, like being thrown from a horse, and a car accident, tripping over an object that's not really there, or some pressure, and it makes you sick. And there's something called espanto, I think that's how you pronounce it, but that's an even more severe, potentially fatal form of susto. And it's indigenously attributed to a soul loss. Your soul is gone due to this intense trauma, this fear, this frightful experience. And it can be a life-threatening illness characterized by lethargy, lack of motivation, insomnia, diarrhea, and is usually treated through spiritual means, some type of ritual cleansing or a herbal tea. But for a U.S. practitioner, they may not understand this. Like, what you've got diarrhea, you're not able to sleep, you really can't get a handle on what's actually going on. This is a folk illness called susto or espanto that's got a big importance in their culture, and they're very aware of it. And this is, I want to share with you this. This is a case study from Justin Purnell, one of our graduate students. Thank you, Justin. And we'll throw this out in our homework to explore a little bit more. But this is an orthosurgical team skull scrub cap that he would wear when he was working in Afghanistan. So take a look at it. And we're going to talk about what could happen. So if you saw your nurse or doctor, healthcare provider come in wearing this skull cap, how would that make you feel if maybe you were from another culture and you saw dead, skulls on the hat? That would be kind of scary. I know with Hmong, when I was working in the camp and the refugees would be sent to America, stories would come back that American doctors ate Hmong patients. So they said, never go to the doctor in America. Whatever you do not go to the doctor, because of this fear that American doctors were eating the Hmong. But it actually wasn't that. They were trying to figure out what was wrong with a patient, and so they weren't eating them, but they were performing autopsies, trying to understand why they died. There's a sleeping sickness that often happens with Hmong young men. One of the issues, but there were stories coming back. So you can imagine what a cap with skulls around it might present to someone from another culture. So we'll talk about that in our homework. And this is another case study I wanted you to think about. I'm going to be going to Cusco, Peru, in a couple weeks, and we'll be doing three things. One, working at an eye clinic, working at a special needs orphanage, and working with abused young girls who are pregnant or recently had a child. And so this is a family from Cusco, from the medical clinic, and this is a typical home in the village of Cusco. And the case study, the issue that we're delving with, and this is something I would love to throw out to you, they've got many people are suffering from cataracts in Peru because of where Peru is located on the map. It's very high in the mountains, and people don't normally wear sunglasses. So our challenge, this is a picture of the clinic we'll be working in Cusco, is how can we encourage the villagers to start wearing sunglasses, because that's an easy fix. It would help to prevent this huge issue with cataracts. So we're struggling with that because no one wears these funny dark sunglasses in the villages. So how would you deal with this? What would you do? Kind of interesting. You can help us for our trip. Then I want to share with you a Hmong case study around birthing rituals. And when I worked in the refugee camp, I wanted to become a midwife at one point. So I volunteered in the labor and delivery room, which was more like a cinder box with a one light bulb, and there'd be rats running around and lizards, and it was an interesting spot. But let me take you, before we go into that, let me talk to you about the Hmong. They tend to be animistic, and they believe that illness is attributed to spiritual causes. Everything has a spirit. And if you're sick, there's usually an evil spirit around. And one's own misdeeds may offend or provoke the departure of one's soul. So if you do something bad, you could lose your soul. And so anyway, here are some pictures of some Lao women. Here's a shaman on the lower right-hand corner. In Laos, the Hmong women would work in the fields until they feel like they're going to have a baby. And then they'd leave the fields alone. When their labor pains would start, they'd go to the forest and they would lean up against a tree. Sometimes they'd bring their mother-in-law, but many times they'd be alone. They would then deliver their baby alone and never, ever, ever utter a sound. Never scream, never sigh, never, because that would upset their ancestors. They would upset the spirits. So can you imagine, you're pregnant, you're working in the field, your water breaks or you feel pain, you go off, lean against a tree with no one around, and you deliver your baby on your own, and you never, ever, ever utter a sound. And you don't have any meds at all. So anyway, these are the Hmong we're looking at. So within the camp, I was working in labor, volunteering in labor and delivery, really just observing for the most part. But so the Hmong women would rather deliver at home alone, but they were told by the folks who were running the camp, UNHCR, etc., that they had to start using the hospitals to deliver their babies. And if they didn't, their babies would not be able to go with them to their third country of resettlement. So in this case, if they didn't deliver in a Thai hospital within the camp, they could not come on to America. So they all went to the hospital to deliver, and they were not happy about it. There were different languages, so the doctors were usually Thai. The nurses were primarily Vietnamese because they are very highly educated. And there was no one speaking Hmong at all. And they were strapped to a bed, unable to move. So remember, they're usually out in the forest, leaning against a tree, walking around. They're strapped in. There are bright lights down, this bright hospital light. There's things flying around. It was not very clean. It was crowded, yelling, chaos in different languages. That's frightening. And can you imagine the familiar and soothing chant of a shaman is so much more reassuring than a sterile American medical hospital. We're talking about here in Thailand, how in a refugee camp, how that crazy it was. But also when they come to America, they really don't want to deliver in U.S. hospitals, but they do. And think about all those cultural challenges. That was one case study, just thinking about. Another one actually took place, was a measles epidemic in St. Paul, Minnesota, where there are many, many Hmong folks. They resettle there. The Hmong comprised about 4.2% of the population, but they disproportionately accounted for 46% of the measles. So the Department of Public Health is trying to figure out, well, what is going on? Why are the Hmong, why are they getting measles so much more often than the average person from Minnesota? So a researcher named Rebecca Henry, she really studied Hmong folk beliefs regarding what causes illness and how this could affect treatment and prevention. And she found that Hmong beliefs regarding immunizations had preventing them from immunizing their children. They didn't immunize their children. They didn't believe in that. They don't understand why you would inject something into the body. I tried to teach mothers why they need to have their child immunized when they came to America, and I was trying to show that they're bad spirits inside the medicine in the they were if they didn't put the good spirits in them, the bad spirits would attack the children in the United States. As you can say, I can't even communicate. It was very, very hard for me to encourage these women to start vaccinating their children. So the Hmong women did not want their children immunized. So anyway, they were infected when this measles epidemic started because they didn't, they weren't protected. So anyway, she instituted a Hmong health education outreach program to address this cultural gap. It was really interesting. And what she learned, she really worked with the leaders of the Hmong community in Minnesota. And she, first of all, they together came up with a solution. First of all, they wanted to learn more about each other's cultures. The Hmong wanted the people from the health practitioners from Minnesota to learn more about their culture, and the Hmong would be more open to learning about their culture. So that sounds good. The Hmong wanted the practitioners to be patient, kind, and positive, open-minded. You know, don't look down on them and say you're uneducated, you don't know what's going on. Be patient, kind, and positive. Avoid negative statements or predictions. Ethnocentrism, remember, avoid those. Improve the translation quality, so actually the Hmong families can understand why they need to get their children immunized. Explain medical terms using visual aids. Pictures are so important, using pictures to explain something. Respect the Hmong family-centered decision-making. The man makes the decision. It's very important to deal with the oldest male when there's a big decision. Don't go to the mothers. Increase the time allotted for the translated clinical encounters, and train Hmong healthcare providers. Train them to become involved in the whole process. And this brings up cultural competency, CE and CME, to educate our providers in the United States more about different cultures. So I thought that was an interesting case study to share with you. And then discussion, how do you think you can more effectively communicate with people from other cultures? So in your career, how do you think you can do that? What if you don't speak the same language? What if they dress differently? What if they wear hijab? They're totally covered, only their eyes are showing. How do you communicate with them? How do you introduce something that might be challenging to understand? What would you do? And then let's talk about behavior change. Let's talk about how to change someone's behavior. How do you make someone do something that's good for them? It requires an assessment of what are the behaviors taking place at the point. What is the extent to which they're helpful or harmful? Are they taking certain herbs that could be harmful or harmless? Is it okay? What are the underlying motivations for these behaviors? Why are they doing that? What are their beliefs? What are the likely responses to different approaches to changing the unhealthy behaviors? So think about these. Think about these 4 points as you design your final health intervention program. Think about the culture you're working with, the target population. Think about what their beliefs are and why they're doing things a certain way. Because if you don't understand why they're behaving in a certain way, you're not going to be able to implement an intervention that will have an impact. And this, we're not going to look at this right now, but this is a fascinating TED Talk called The Last Mile. It's Senthil, his name is Senthil Mullainathan. And it's called Solving Social Problems with a Nudge. And basically, it's very interesting. He is a behavioral economic major, and he's trying to apply behavioral economics to study social problems, like how do we change behavior? Why don't people change behavior? We know how to reduce child deaths due to diarrhea. We know how to prevent diabetes-related blindness and amputations. Yet somehow people don't change behavior. Why don't they change behavior? Why do I always start a new diet, a new way of eating every Monday? And why can't I keep to the eating behavior? Why can't I stay on a diet? Why can't I change the behavior? Why can't I exercise every day? Why? What are the barriers in place? So anyway, this is called The Last Mile. And it's kind of interesting in terms of trying to understand why it's so hard to change behavior. And along those lines, I just want to share with you 4 psychosocial theories that are used to predict, explain, and change health behaviors. And I would love for you to include one of these in your final project intervention. I don't know if you've studied these before. The trans-theoretical model, also called stages of change, the health belief model, the theory of reasoned action, and the diffusion of health innovations model. So let's take a look at these very briefly. The first is a trans-theoretical model. This is my favorite model. I use it many times. The author of this model, and you can't see the picture well, but it's Dr. James Prochaska and his former doctoral student, Di Clemente from the University of Rhode Island. And they created a model of change whereby they looked at change as a continuous process. Different people are at different stages of the process. So let's look at this. So here we're at these different stages, and there's different versions of this model, but I use this all the time. So when you look at someone, are they in the pre-contemplation change, meaning that they have no intention of changing their behavior. So for instance, let's talk about me and eating. Do I realize I've got a problem with my weight? Should I be changing the way I eat? Do I think there's a problem? If I'm in pre-contemplation, nope, I've got no problem. I'm great. If I'm in the contemplation stage, maybe I'm aware, my pants are a little bit tighter, I'm feeling sluggish, I'm feeling large, I think I might have a problem. Preparation, well, I'm going to start my new eating plan on Monday. I'm going to buy all the foods I need for the week. I'm going to prepare to take action. Then action. I'm going to start Monday morning. I'm going to start modifying my behavior. I'm going to start eating well Monday morning, and I'm going to keep doing that as long as I can. And then maintenance. Are we going to be able to sustain this change and replace our old behaviors with new positive behaviors? So am I going to stop eating McDonald's every day and instead have a healthy protein shake for breakfast? Am I going to be able to hold this and maintain it for a long time? Or am I going to relapse? Am I going to go to a party where they're going to have chocolate cake and I'm going to eat the chocolate, and then I'm going to eat the ice cream, and then I'm going to have some wine, I'm going to have all these unhealthy foods, and I'm just going to be a mess for the next 2 months? Or David Shames believes that you can get right back on the cycle again. So you can relapse, but then get right back, go to pre-contemplation, contemplation, and start again. So they believe that change is continuous, and I love that model. You're always changing. Then there's something called the health belief model, developed by Erwin Rosenstock in 1965, and you can't see him again because of my view. I'm sorry about that, but he's from the University of Michigan. And it was originally created to study and promote the uptake of health services. It assumes that health behaviors depends on one's perception of their likelihood that they're actually going to get the illness, that they're going to get sick, the severity of the illness, the benefits of engaging in behaviors that prevent the illness, and barriers to engaging in preventive behaviors. And there has to be the self-efficacy, which determines whether or not people feel they can carry out the behavior. And it's based on Albert Bandura's social cognitive theory. This is often used in with health interventions. The health belief model proposes that people will respond best to messages about health promotion and disease prevention when 4 conditions exist. When he or she is at risk of developing a specific condition. For instance, if I'm engaging in risky sex, do I feel like I can get an STD or HIV? Do I feel like there's an issue there? The risk is serious and the consequences of developing the condition are undesirable. I do not want to get HIV, and it's a very serious risk. I understand that. 3, the risk will be reduced by a specific behavior change. If I use a condom, I won't get HIV or an STD. And finally, 4, the barriers to behavior change can be overcome and managed. I know where to get condoms, I can get them at the health services on campus, and I can use them, and I can manage the process. And this is an application of the health belief model using condom use, the example, like I was using risky sex, or an STD screener, HIV testing. So there's the perceived susceptibility of the person, their severity, their perceived benefits, the perceived barriers, the cues to action, and the self-efficacy. This is the health belief model. And then there's something called the theory of reason action, or the theory of planned behavior, created by Dr. Asjen and Dr. Martin Fishbein, excuse me. And this model has been used successfully to predict and explain a wide range of health behaviors and intentions, including like smoking cessation, like drinking, alcohol, health service utilization, going in for tests and preventive tests, breastfeeding, substance abuse. It's been applied many, many different times. And basically, they have 2 conditions. So you have a person's belief that the behavior leads to certain outcomes, and his or her evaluations of these outcomes, leading to attitudes toward the behavior, their intention of the behavior, and the person's beliefs that a specific individual or group thinks that he or she should or should not perform the behavior. And this motivates them. And this is like the subjective norm. So we've got the attitudes toward the behavior, the subjective norms, They both focus on the attention and the behavior if you're actually going to change the behavior. And sorry about that. We jumped. So anyway, this is the theory of reason action, or the theory of planned behavior, which would be useful to use in a program. Goodness, this is jumping. And the fourth and final one we're going to discuss is one discussed by Everett Rogers. Once again, you can't see his face. It was developed in 1962 by Dr. Rogers. It's one of the oldest social science theories. It was originated to explain how, over time, an idea or product gains momentum and diffuses or spreads through a specific population or social system. I love this. The end result of this diffusion is that people, as part of the social system, adopt the idea, behavior, or product. So how do you adopt? How does a new idea come into play? Like, how does everyone start using seatbelts? Or how do people start thinking that smoking is bad, or whatever it may be? And adoption means that a person does something differently than what they had done previously, like purchase a new product, acquire and perform a new behavior, like condom use. The key to adoption is that the person must perceive the idea, behavior, or product as new or innovative. It is through this that diffusion is possible. So the product has to be new and innovative. So let's look at the schema here, the diffusion of innovation. We have the percentage of adopters here on the left, and over the time, the innovators start here on the left. The early adopters begin at about 13%. The early majority, then the late majority of those who come on later, and finally the laggards who adopted behavior way down the road. So this is diffusion of health innovations model, which is kind of interesting to explain behavior change as well. I also wanted to share something called asymmetric paternalism, and I love this. And this means it's a public policy solutions targeting self-harming behaviors, like if you're going to use a seatbelt, or you're going to promote health foods over unhealthy foods. For instance, if you want to promote, you might provide water and only to people at a restaurant, and only provide soda if someone asks for it. So you come and you don't see any soda, you'll just have the water that's there, unless you really ask. Say, do you have any soda? I want some soda. Or maybe you move unhealthy foods way away so you don't see them. So you walk into the restaurant, you see all the healthy foods in the front, and the unhealthy foods are in the back. You really have to look for them. Or you can use it to promote healthy behaviors, like scheduling certain medical tests, like mammographies or colonoscopies. Or like employers at my last company, if we signed up for the health plan and we visited the gym twice a week, they would pay for our gym membership. So this is like asymmetric paternalism. It's policy solutions that are aimed to making people change their behavior from bad to good. And this is like in New York, I think it was Pataki who outlawed the big gulp sodas. He said you can't sell them anymore because they're so incredibly caloric and unhealthy. And then understanding and engendering behavior change, you can look at community mobilization. And once again, you can think about this for your projects. You engage the entire community in your effort to identify problems and promote healthy behaviors. If you can get everyone involved to identify these bad behaviors, they'll be more likely to participate. And then you leverage the leaders in the community who are your champions. They can encourage people to change, and they can sustain your program over time. So if you're going to be implementing your program in a village, you want to make sure you get the village elders or the leaders involved and in support of the project. Because if you have a project and you're going to implement it and you don't have those village elders in support, no one will come to your program. It doesn't matter if you're giving away free whatever, they're not going to be there if the respected folks in the community don't support your program. So definitely think about that. And then also you may want to leverage mass media, radio, or educational performance to get a message across. Like their public service announcements, which are great examples of positive health-changing behaviors using mass media. I remember once I was in the north of Thailand in a village, and we were woken up at 6 a.m. on Sunday with a loudspeaker announcing it was a condom usage. They want to encourage people to use condoms. It was 6 a.m. on Sunday morning, loudspeakers to the whole community, try to encourage people to start using condoms. I thought that is absolutely crazy. But that's what they had. So they just promoted it all around. Or I know in India and Thailand, they have soap operas that they're focused around reducing risky sexual things. So they, in the soap operas, they'll use condoms and they'll talk about issues to try to change behaviors in a positive way. So anyway, and public service announcements, we see them here all the time. Also something called conditional cash transfers. This is when a government agency provides an economic incentive for families who engage in a specific healthy behavior. For instance, in Thailand, I was there when if a man in a family who had a child, would come in for a vasectomy, they would A, get that vasectomy free, and B, they'd get a free cow. So, and that's a big, great value, get a free cow, so everyone wanted to have vasectomies. So the government providing economic incentives to motivate people to change their behavior, and that's always in support. If you can get the government behind you in your program, you're going to be doing well. And also, we'll talk about later, but Thailand and condom usage, the government was 100% behind ensuring that all the brothels had condoms, that all the prostitutes used condoms with their customers. And so it was this 100% condom usage program that was extremely successful in the 80s. Something else I want to talk to you is health literacy, which means the degree to which individuals have the capacity to obtain, process, and understand basic health information, and it helps them to make appropriate health decisions. So what is your health literacy to understand the health topic that if you're a provider, you're going to be talking to your patient about? How is your patient going to understand it? I remember when I worked with type 2 diabetics, you say, do you have diabetes? I say, no, I don't have diabetes. No, I've got high sugar. I've got a touch of sugar. Or just last weekend, I saw a woman at a conference. She tripped and she fell and she was just dazed. And we went over to help her. And her son was there and he was helping her as well. And we said, what happened? We're trying to figure out what it was. Perhaps could you have diabetes? She said, no, I don't have diabetes. I don't have diabetes. And her son said, yes, she has diabetes. And he said, Mom, but you have high sugars. She said, yes. So health literacy is really important in speaking with your patients. And one thing you need to think about with health literacy, 25% of the U.S. population cannot understand basic written material. 1/4 of the population. Think about in other places in the world who may not be as literate. People with low literacy are more susceptible to hospitalizations, and many it's because of medication errors. So what we do here with the companies I've worked with in the past, we create all materials at a second grade reading level so that there are no problems. We did this at Pfizer, Active Health Plans, NHPA, everything we created, it was at a second grade reading level so that there wouldn't be any issues, and that always helps. Indicators of low literacy might be like registration forms are filled out incorrectly or they're ineligible. So you can see the target population. If you're creating a program and people are not completing your applications appropriately, maybe they're not understanding them, they've got a lower literacy rate. Health questionnaires might not be completed to the fullest extent. Appointments are missed by the patients. There are medication errors. A lack of follow-up with referrals, lab tests, whatever it may be. And patients may always just say, I forgot my glasses because they're embarrassed. They don't want to say that they can't read or they have a low reading ability. So something to think about once again in your programs. And finally, I want to talk to you about cultural competency. And this is huge. I've worked on a number of different cultural competency programs over the years. It's basically, cultural competency means a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables effective work in cross-cultural situations so that there are no barriers. You want to eliminate all the barriers. Culture refers to integrated patterns of human behavior that include the language, thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. And finally, competence implies having the capacity to function effectively as an individual and an organization within the context of the cultural beliefs, behaviors, and needs presented by consumers and their communities. Cultural competency is very important. There are many continuing education and continuing medical education programs focus on improving cultural competency here in the United States so that we can understand and really help and pinpoint the problems of folks from other countries who may be of different cultural backgrounds. And I've worked many years with this gentleman, Dr. Benincourt from Harvard. He's one of the leading cultural competency experts. He was the director of the Disparities Solution Center, a senior scientist at Mass General Hospital. Anyway, he's published extensively on the topic of cultural competency. And why is it important? It can close the disparities gap in healthcare. That's number one. It impacts the way patients and doctors discuss health concerns without cultural differences hindering the conversation. Instead, it enhances it. So the provider understands the needs and the issues of the patient. The patient understands why the provider may be asking those certain questions. And healthcare services that are respectful and responsive to the health beliefs, practices, and cultural and linguistic needs of diverse patients can help bring about positive health outcomes. And finally, this is just the CME portion I was alluding to. In New Jersey, the New Jersey Board of Medical Examiners, they mandated that every licensed physician completes a 6-hour CME requirement for cultural competency during their licensure. So this is very, very important. In the United States, working with people of other cultures. So anyway, that was our presentation on Module 3. Thank you so much for listening to the whole presentation. I want you to think about everything we talked about in this module for your final projects, and also in your jobs, your careers. It's really important to understand someone's culture, not to make uninformed, judgmental decisions. And anyway, so have a great day. Thanks so much, and I look forward to hearing from you. Have a great day.
Pacha shakes for the first time in America. He is anxious to reestablish contact with ancestral spirits. Chickens are used to open the altar because they have special powers to see and know. That's why the spirit of a chicken is used as a messenger and guide on journeys to the spirit kingdom.